So we're going to be talking about implantable defibrillators and implantable pacemakers and how to use surgical energy around those. I have no disclosures, and you know, with an aging population, this is a more and more common scenario where you have a patient who's got an electronic device, and actually it doesn't, this is focused on cardiac devices, but you know, there's also other electronic pumps, you know, for pain, for all sorts of different reasons. So how do we want to use our high voltage energy device in the setting of these other electronic devices? There's two practice guideline statements out there, and I'm going to lean heavily on those. And if you want, you can email me. I'm happy to email you either one of these articles. Notably, the bottom one has some very nice recommendations that I'll go over for how to manage a cardiac device, an implanted cardiac device in an urgent setting. And so here's the three topics that I'm going to go over. The three topics are, number one, the preoperative evaluation. What I'm going to focus on is really when you're in the urgent setting. Just knowing two different facts and having a very simple algorithm. If you have a patient in the middle of the night who has an implantable device in place and you don't know what it is, I'll show you how you can figure out what it is and then what you should do about it in the operating room. I'm going to do just two slides on intraoperative monitoring just because the fuse test really has a bunch of questions on that, and so we might as well get those questions right. And then finally, we're going to go over, when you're actually in the operating room, how can you minimize the interference that you're creating on that implantable cardiac device. All right, so here we go. So you have a patient and it's 11 o'clock at night and you need to take them emergently to the operating room for, you know, abdominal sepsis. And so you need to go. And of course, the best way to know what kind of device a patient has is you should be able to ask the patient or get it from the medical record. Or often patients will have a card with them that will say, this is the device and these are my current settings. But I think as most people know that sometimes the patient won't know what their device is. But that's clearly the first line is just a history. And if they don't know, what we need to do is we need to figure out, is the device a pacemaker or a cardioverter defibrillator? And the second piece of information we need to know is the patient pacing dependent? And so the two things, the first thing, so let's answer the first question, which is it a pacemaker or a cardioverter defibrillator? And so how you do that, if the patient doesn't know, is you can take a chest x-ray. And when we look at these chest x-rays, they both clearly have a generator. This is in the left upper chest wall. The cardioverter defibrillator will have a coil of wire down by the tip. So you see that opacity there? That's thicker than the rest of the wire up there. Where a pacemaker, the wire will be all uniform all the way up. So if you have that coil right there, that's what stores the charge and then delivers the charge to change the rhythm when you have a tachyarrhythmia. So that's how you can tell the difference if the patient doesn't know. The second piece of information, then I'll tell you what to do with this information in a second, but the second piece of information is the patient pacing dependent? And so you just get a 12-lead EKG. And the guideline statements consider a patient pacing dependent if most or all of the QRS waves have a spike in front of them. So you can see the pacer spikes here. These would be atrial pacer spikes. So this would be a pacing dependent patient. Here is a ventricular lead. So you can see it's right adjacent to, and every single one, so this patient is pacer dependent. And so if you have that pacer spike in front of the majority or all of your QRS waves, that's somebody who's pacing dependent. So based on those two pieces of information, we're going to go into what you actually do. And I put a picture of a magnet here. So this is a magnet. Who here has used a magnet in the OR? So, and a lot of surgeons kind of think that a magnet is kind of a get-out-of-jail-free card. It's like, oh, just put the magnet on it and it'll be fine. And I think that there's something to that, but I'm going to actually explain what the magnet does, because it does. Magnets work differently on pacemakers than they do on the cardioverter defibrillators. All right, so let's start. We're going to start with the pacemaker, and the next slide is on the cardioverter defibrillator. So if the patient is not pacing dependent, in other words, the native heart rate is working, the native electrical system of the heart is working, you should always have a magnet available. You should always be putting on your external pacing pads, but you can just perform the operation. So you just proceed with your operation. If the patient is pacing dependent, which is a much higher risk patient, right? That's a patient who's relying on their device for their heart rate. You should be trying to use your energy in a way that doesn't disrupt the electronic device, which I'm going to spend 5 minutes on that here at the end. You should place a magnet over the device if the procedure is above the umbilicus. So if you're above the belly button, you should then use a magnet. And what does a magnet do to a pacemaker? Well, it puts it into an asynchronous mode, and an asynchronous mode is a fixed rate mode. So basically what it does is it turns off the pacemaker's sensing capacity, where it senses the native heart rate, and it just converts it to a fixed delivery of beat. So it's not sensing anymore, so it doesn't get disruptive. So if the operation's below the belly button, you can just do that operation without a magnet in place. If it's above the belly button, then you should be putting a magnet over the pacemaker, always putting on, this second one I think is key, always putting on your transcutaneous pacing and defibrillator pads, because you don't want to be scrambling doing that if you run into some problem. So the guidelines are a little bit different for the defibrillator or the cardioverter defibrillator. So when you put a magnet over a cardioverter defibrillator, what it does is it turns off its ability to sense the tachyarrhythmias. But you still have synchronous pacing, so there's still a sensing mode on that device which senses the native heart rate. And so for that reason, we're placing a magnet over the device. Once again, and in this case, even if the operation is below the umbilicus, we're still placing a magnet over the device. And that's why it's really important to be able to determine. So if we remember from that chest x-ray, the defibrillator is the one that's got that coil or that big radio opacity next to the tip, because that's what stores the charge to deliver it. So with those 4 simple sort of steps, that's a way that you can safely manage by the guidelines a patient in the middle of the night who's got a cardiac implantable electronic device that you may not know what it is. I'm going to put 2 slides up here on just the intraoperative monitoring. And suffice it to say, so there's the normal ASA monitoring of a patient, but when you have a patient who's got a cardiac implantable device, you should also peripherally be checking their pulse. And the 2 ways to do this would be an arterial line, because you can see on your EKG rhythm strip, you can have electromagnetic interference, so you don't have these nice spikes, and then you don't know what's going on here, but you need your A line. And the next one has actually a pulse ox on it. It's the same sort of rhythm strip, but it's got a pulse ox on it. So I'm trying to forward the slide. There it is. And once again, you can see that the patient is perfusing here, even though your rhythm strip doesn't show it, because as many people know, your monopolar inhibitor, the Bovie, since it's such a high voltage device, it can disrupt your EKG strip. So you need to have some other sensing, a peripheral sensing of the pulse, whether it be pulse oximetry or an arterial line, and there's a number of questions on the fuse test. It's very straightforward, and they're easy ones to get, but I think it's worth mentioning that. Then my final section here is simply, when you're in the operating room, what are the things that you can do as a surgeon that are going to minimize the amount of electromagnetic interference or the disruption of this electronic device that's implanted in the patient? And I'd like to recognize, when we do this, I'd like to recognize Mark Rosner, who's an anesthesiologist here in Houston, or was an anesthesiologist here in Houston, who was really one of the founders of the FUSE program, and this was really Mark's module, and Mark passed away this past year. But Mark actually came up, the study I'll be presenting from, he actually came up to Colorado and worked with us in an animal lab, figuring out some of the information that we're going to be telling you. So what are the things that you can do as a surgeon that are going to change the amount of interference on the implantable cardiac device? We've got 7 things here. So the proximity of the active electrode to the implantable electronic device. This is intuitive. I don't think it's listed in every textbook. I don't think it's very helpful, though, because you can't really change where the device is or where your operation is, right? And so, but I do think it's worth noting. And both the guidelines and evidence that we generated in the lab show that you should avoid the proximity of electrosurgery, your monopolar pencil, to the generator or the leads of the generator. And there's a nice dose response. So as you move further and further away, what we did is we were in an anesthetized pig, and we had a pacemaker in place, and we activated right over the tip of the lead, and then 2.5 centimeters, 5 centimeters, 10 centimeters, 25 centimeters, and 40 centimeters away from the tip of that lead. And you can see that once you're about 10 centimeters away, it kind of plateaus out. And I think that this information kind of backs up that below the umbilicus rule, right? So we learned that if you're operating below the umbilicus, we really don't have to worry about putting a magnet on that implantable pacemaker. And I think that the data really backs that up. But again, I don't think that this is as useful because you can't change your operative site or you can't change where your pacemaker leads are. But what you can change is where your current pathway is. And what the current pathway is I'm going to show you a picture. Let me show you a picture of it here. Your current pathway is essentially the pathway between the tip of the pencil, where the current is coming out. It's actually alternating current. It's going back and forth. But imagine the current, and then it goes to the dispersive electrode, which is down here on the leg. So if we position the dispersive electrode up here on the shoulder, right, then your current pathway is going to be going right up through the cardiac implantable electronic device, and we would not want to do that. And so putting the current vector so that it does not go through the electronic device or its leads, that's something as surgeons we can modify and we can change in the operating room. And we showed this in the animal model that you have a less electromagnetic interference. And the example that Mark Rosner always loved to give, so Mark was an anesthesiologist at MD Anderson, and they gave him all the cases in the chest wall and stuff, the breast cases when people had these cardiac devices in place. And the example he would always give is that if somebody's getting an operation for like a melanoma or a lesion on their left shoulder, right, so they've got the device in right here, the place to put your dispersive electrode is actually out here on your, I'm sorry, this is the right, out here on the right arm, so your current vector goes straight away and it never goes across the device. So if you're operating up here on the shoulder, you would not want to just place your dispersive electrode down here on the right thigh or the right gluteus, which would be the traditional place to put it. So think about your current vector. That is a modifiable factor in the operating room. All right, orientation of the active and dispersive electrode cords. This is really not addressed in the guidelines, but there's very good evidence when we were in the lab that if you basically, and what this means, I'll show you a picture of it, if you have your monopolar generator, say at the top of the bed or on the shoulders, and your dispersive electrode and your active electrode cords are going close to the implantable cardiac device, you get a ton of electromagnetic interference. Your dispersive electrode cord is carrying as much energy as the active electrode cord, so it's similar between those two. I should have put in this picture for this figure the dispersive electrode cord too. What you should be doing is you got to move, you got your monopolar generator on a roller, you got to move it down to the foot of the bed so that the cords are coming down from the foot and that they're not in close proximity to your cardiac implantable device. That is a clearly modifiable thing that you can do in the operating room that's going to reduce the amount of interference. And that goes along with this whole thing that if you're below the belly button too. So if you're below the belly button, you drape your cords up from below, at least in our lab, there's very little electromagnetic interference on that cardiac device. The other thing you can do, and the anesthesiologists are always interested in us doing this, they're like, well, don't use the monopolar instrument. And I'm like, well, I want to use the monopolar instrument because, I think that gives me the best sort of tissue effect. But I think that if you can use a different energy modality, that would be beneficial. Beneficial meaning you don't have as much interference of the cardiac implantable device. Bipolar and ultrasonic devices had the least electromagnetic interference. Monopolar devices were in the middle, and then the plasma devices like the argon beam, we have a very high voltage crossing the energy across that spark gap. Those were the worst for electromagnetic interference. So, but if you could use a traditional bipolar, advanced bipolar, or an ultrasonic device, that would have less of electromagnetic interference. And I do think it should be recommended, although clinically I don't see that a whole lot. I'd be curious to see if other people try that. So generator power setting choice, I think it's intuitive. The lower you set your power, the less electromagnetic interference you have. Generator mode choice, you want to use generator modes. The mode is the cut versus coag mode. So you want to use the low voltage modes. So if you can be on a cut mode or a blend mode, that's going to be beneficial. And then your choice of surgical technique, I don't think that's as modifiable because you want to be using the tool to get the best clinical effect. But it's pretty clear that desiccation, or when you're touching the tissue, because the generator is putting out a lower voltage, that is protective. And we showed all of those in the animal lab, and I think you can hang your hat on all those. And these are all in the guideline statements. So this is the last slide, and I'll leave this up while we take questions. But I think the modifiable factor is what you can actually do in the operating room is you can lower your power setting. You can drape the cords from down low, so you can position your cords optimally. You got to be the most powerful predictor in our lab was the placement of the dispersive electrode. So routing that current vector so that it does not travel up through the electronic device, that was critical. And the final thing is if you can use the ultrasonic device or if you can use an alternate energy source, that would be a great thing to do. So thank you, and I'll take any questions. It looks like Pascal, you're coming up.
Spinal cord stimulator is another big one. I had to do an open emergency bowel resection, and I used bipolar for everything, including the skin and the fascia, and you can do it. Yeah. Tell me again why I can't live with a knee jerk. I put a magnet on every case. Tell me again why that's not the right answer.
Okay, poor Mark would roll over. So the electrophysiologists do not want you to just use a magnet in every single case. And so the reason for that is there is, and I think that this may be historic, but so when you put a magnet on, when you remove it, your generator doesn't always go back to the initial settings that it was on. And so in the guideline statements, if you ever use a magnet or if you ever do an operation on somebody with a cardiac implantable electronic device, you're supposed to reprogram it at the end of the case. So when you put a magnet on it, it's going to, for a pacemaker, put it into asynchronous mode, and that generator does not always go back to those initial settings. So that's what Mark would say. And then the second comment, just because we'll get to your next thing, is that the other thing, and Mark was really big on this, he thought that because healthcare is so fractured, right, so somebody will get their cardiac implantable electronic device at their private cardiologist's office, across town, and they will work with their cardiologist to get the right settings so that they feel good, they have good ejection fractions, but those settings may not be known to that hospital system, and so the thought is essentially that if you reprogram the device without the knowledge of whoever put it in or who's really tuning it up, that you're going to change the settings and then the patients don't always follow up, and so you sort of, you disrupt their normal cardiac settings where they're living optimally. Those are the two reasons, Pascal.
So back to my question, because it's really a question for the test takers in this room.
Oh, I see.
Now, can you answer it again? So basically, when are these questions? And that was, for me, the most difficult questions to answer were these pacemaker questions in the test. So I wanted to, again, could you re-answer the question and let me put it differently? In which circumstance do you not put is the right answer not putting on the magnet?
The magnet. So
because in our practice, that's what we would do.
It's the default, and everybody thinks
right.
It's good. So I think
can you specify again for the test?
And I believe that the stem of that question is, it's really the location of your operation. And so if you're below the umbilicus and you have a pacemaker in place, there is absolutely no indication to put on a magnet. And I believe that's the question that Pascal is getting at. If you have a cardioverter defibrillator, in both instances, whether you're above or below the umbilicus, you should be putting on a magnet for those. That's what the current guidelines from 2011 say. Any other questions on this? Okay, thank you.